Because Dr. Darshana Rathod. So she is the traditional director department of the critical care medicine of the Sir H.N. Reliance Foundation Hospital, Mumbai. Experience in critical care of 24 years. CPISQ certified and SQA fellowship for quality in healthcare. It is experience in quality for more than 20 years. So welcome, ma'am.
Been given to speak today is on prevention of device-related infections, the latest developments. It's a broad topic, but I have tried to cover it up in a short time as well as with the latest guidelines and concentrating on what are the most important parts. And being a critical care person, I come across it every day, as well as it's been years of experience which has taught me many things, not only to me, which I have learned, but in and discussed with our teams and tried to implement in our day-to-day practice. So we all know that device-related infections are the major cause of healthcare-associated infections, and the bundles are all a structured sets of interventions which are aimed at reducing these rates. And also these presentations which I'm going to do today is all on the preventive bundles that we are going to talk about. So burden of outcomes associated with CLABSI. Let us start with CLABSI. It is one of the most commonest infections which we come across in a hospital setting because it not only increases the length of stay, it increases the cost, increases the morbidity and mortality. It is the 8th leading cause of death in US. And one of the things which everyone needs to know is how to calculate the rates. So it is per 1,000 central line days that we calculate the rates of the infection. Risk factors, yes, first it starts with the ICU population because that is the place where we normally land up putting up the catheters, and there are situations wherein in an emergency situation that we put up these catheters. Vulnerable populations are the populations who are on hemodialysis, have malignancy, and nowadays, if we see over the last few years, one of the new things which we all come across is on the mechanical circulatory devices. What I mean by it is the ECMO cannulas, the intra-aortic balloon pumps. We have our transplant patients who come with BIVADs, LVADs. So all those patients are also the vulnerable populations which we come across. And one more thing which has come up with, again, the detection of malignancy, which has become very fast. There are patients who get chemotherapy. There are patients who are on short-term peripheral catheters or PICC lines, midline catheters. And again, one more setting that we need to understand is the home care setting, which is another one thing which has really started as a good thing for the patient and the family, but it is also one of the factors which is very important if the patient goes with lines and tubes. Independent risk factors, definitely prolonged hospitalization, prolonged duration of the catheter, heavy microbial colonization at the insertion site as well as at the catheter hub, multilumen catheters, concurrent catheters, multiple catheters. If the patient has neutropenia, if the BMI is more than 40, if the patient is at a gestational age, reduced nurse to patient ratio in the ICU, parenteral nutrition started, substandard catheter care, and also blood transfusion, especially in the children. So whatever I'm going to talk today is based mainly for the WAP prevention and for the bloodstream prevention, bloodstream infection prevention is based on the SHIA paper, which is the most recent guidelines and which is of 2022. And these guidelines and recommendations are very good because it is an entire team who has sat together and based on the so many years of recommendations, they have come up with these beautiful things and really put it down very nicely. So there are a lot of changes which you see which have been put up, and they have been very well put up so that it is easier for us to understand. So the way they have done it for a central line that a patient should have, first of the recommendations that they've given is the infrastructure requirements. So it has to have an adequately staffed infection prevention and control program. So if it is a hospital, you have to have a proper HIC program. And not only the HIC program, it should have the staff who is there to deliver the program. And also there is some kind of technology which is there to collect and calculate the surveillance as well as the catheter days and give us the information as soon as possible, resources to provide appropriate education and training. And also very important will be the laboratory support because we all are dependent on the laboratory support for timely processing as well as giving the reports to us so that the patient is attended to as fast. And we all know now of the sepsis bundle, which is very much there, the 1 hour bundle, the 3 hour bundle. So if we know, then there are two things which will happen. We will treat the patient with the right antibiotic, and we will avoid any antibiotic resistance to the patient, as well as take care of the required antibiotics. Then they have put up categories of recommendations. This is very nicely put up into essential and additional approaches. So for CLABSI, essential practices are the potential to affect CLABSI risk clearly outweighs the potential for undesirable effects. And it should be adopted by all acute care hospitals. So essential practices has to be adopted by everyone. Additional approaches can be considered when this CLABSI is not controlled by the essential practices, and here the intervention may not show us the much of a outcome, but let us see if the intervention is likely to reduce the risk. We can very well use it. Quality of evidence is low, cost to benefit ratio may be high, and impact of this kind of additional approaches is mainly done in certain settings like outbreaks or in special populations. Then it is again giving you a quality of evidence. So quality of evidence is divided into high, moderate, and low. High is there are a wide range of studies with no major limitations to the studies, and it has a narrow confidence interval. Moderate is only few studies, some have limitations, and the estimate has wide confidence interval, and low is the supporting study has major flaws, and there has been a very wide confidence interval. So going forward with this understanding, let us look into what are the essential practices for preventing CLABSI. So any bundle that we go across, we always start with before insertion. We all know about it. So here high importance is given to that. So practices that have to be taken before insertion is definitely the patient has to be prepared very nicely and has to be cleaned very properly with a chlorhexidine preparation on a daily basis. So daily care equally becomes very, very important. Moderate is education and competency assessment of the all the healthcare personnel who are involved. Now, this competency assessment we have seen mainly in many hospitals. It is done only at the nursing level, and in the physician level, it is done up to the clinical things that we normally do, but it also involves in the infection practices. And so competency assessment has to be a part of our insertion bundles also, especially for the CLABSI prevention. And low is provide easy access to an evidence-based list of indications for CVC use to minimize unnecessary CV placement. This may not be possible because sometimes the patient may have poor access and many other factors which may be there. So we need, it is carrying a low evidence. Then comes the essential practices for preventive CLABSI at the insertion level. Here, the high is use an alcoholic chlorhexidine antiseptic for skin preparation, use ultrasound guidance for catheter insertion. This avoids double pricks. This also ensures a safe practice. And subclavian site is the most preferred site because it is the most safest site. It is very easy and contamination is less likely. Moderate is in ICU and in non-ICU settings. It should have a checklist to ensure that these practices are put up. So one of the ways to incorporate it is also to add it to our timeout checklist. It can become one checklist which is used easily. Perform hand hygiene prior to the catheter insertion or any manipulation. There has to be a proper hand hygiene. Hand hygiene is one of the things which is applicable for our entire presentation. Use an all-inclusive catheter cart or kit. It really helps because it avoids the traffic and everything is there in that kit. So nurses do not have to go around and run around. And also the procedure can be done faster. And use maximum sterile barrier precautions during CVC insertion. We all know that we cover the patient up to the foot end and see to it that even the edges of the beds are covered so that there is no contamination and lines are safe over there. There is nothing as a low at the time of the insertion. Then comes for the after insertion. High is ensure appropriate nurse to patient ratio and also limit the use of floating nurses over there so that it is not handled by many people. Use of chlorhexidine containing dressings. Then routine replacement of administration sets not used for blood or blood products can be performed at interval up to 7 days. And perform a surveillance for CLABSI both in ICU and non-ICU settings. This is something which we need to do. Moderate is for non-tunneled CVCs, both in adult and children. You have to see to it that the transparent dressings are changed every 7 days, unless there is any soiling, or if it is damp, or if it has become loose, then we can change it every 2 days or as and when required. Disinfect the catheter hubs, needleless connectors, and injection ports before accessing the catheter, and remove non-essential catheters. These are the moderate practices. Additional approaches for preventive CLAPSI. High is use antiseptic or antimicrobial impregnated CVCs. So in this antimicrobial impregnated CVCs, we use it mainly where we see that this patient is going to be a chronic patient, may require multiple dialysis, may require the central line for a longer time. These are the patients where we use it. Use antimicrobial lock therapy for long-term CVCs. This is especially for patients with long-term HD catheters and recurrent CLAPSI, or a limited venous access and history of recurrent CLAPSI, and at high risk of severe sequelae from either any intravascular device or a prosthetic heart wall or a aortic graft. We get patients of infective endocarditis also who require the antibiotics for a longer time. And use of antimicrobial ointments only for hemodialysis catheter insertion sites. This is something which we have not used, but we will look into it and we will try to see what are the practices which others are using. Moderate, use an antiseptic containing hub or connector or a cap or a port or protector to cover the connectors. We all know about the curios which is there. And low is utilize infusion or vascular access teams for reducing CLAPSI rate. I don't think that is going to make much of a difference, because at the end of the day, it is anyone who has access has to see to it that hand hygiene is done and all these measures are followed, what we have been saying. Approaches that should not be considered a routine part of CLAPSI prevention is very important. So do not use antimicrobial prophylaxis for short term or while catheters are in C2. So if the patient requires just a central line for any antiarrhythmics that we need to give, like Cardron or something, because we don't give it to avoid thrombophlebitis, we use it there. We don't need to sit and do a antimicrobial prophylaxis. Do not routinely replace the CVCs or the arterial catheters. These are the high quality evidence, and this is something which should be practiced, and we practice it in our unit also, so we are lucky we are doing it. Implementation of CLAPSI prevention strategies is by following 4 E's, that is engage, educate, execute, and evaluate. So for anything that we need to do, we need to also ensure that the implementation, there is a way of implementation. And to do it, we need to see to it that both the frontline, the senior leadership, everyone are a part of the plan, as well as to get it done by the required stakeholders from different facilities. It requires everyone. It's not only the nurse, it's not only the doctor, it's not only the infection control person, it's multiple people. It is visiting consultants also who come to the ICU, and many more healthcare workers, the person who is giving physiotherapy. So multiple people who are touching the patient have to be involved. And educate is by seeing to it that we have given a proper education for the indications before insertion, use of the full barrier precautions at the time of insertion, and daily evaluation of the necessity of the device. Executing is by doing a competency checklist, which I already told you, and seeing to it that this competency checklist is by everyone, not only the nurse, but also the physicians who are there, who are inserting the lines. Education of the patient and or family as appropriate. This is very important because in today's world, we know many of our patients get home care. And also our patients who are going with dialysis catheters, or also the perma cats and multiple catheters that they have. So these are the patients where the family also and the patient also needs to know on how to take care of those lines. And this can be done by putting up good education ways, and you can give it at the time of the discharge with the proper instruction, make it into formats with nice pictures, as well as in the vernacular language, which is easier for everyone to understand. So this is something which is equally very important. Otherwise, we'll end up with patients coming with MRSA, and that becomes a big problem. Evaluation is both about the process as well as the outcome. We always measure outcome, but we also need to look into what are the processes and how we are performing on the processes. And the feedback is not only at the level of the at the HIC level, where we discuss in our HIC committee meeting, but I believe that the feedback should be given by whoever is coming to check it as a surveillance, should check and give it to the staff at the same time, so that the corrective measure is done at the same time and the staff remembers that this is something wrong and I should not be repeating it. And then there are something which is new thing, a standardized utilization ratio, which we can do. There is an entire thing which is given on CDC, which you can go through because there is an entire guideline on how to go about with it. So like SMR, we can look into SUR also. So there are definitions for the process measures on how to do the calculation, how to bring out this process measures, how to assess it. So if you see just a simple example, use of proper CVC insertion, the three things which are very important. So number of CVC insertions that have documented the use of all three interventions performed at the time of CVC insertion divided by the number of all CVC insertions into 100. So this will give you a percentage of the compliance to this practices and multiple definitions. Further, this Shia paper is a very good paper. Everyone should go through it and should see to it that you can apply it to your day-to-day practice. And then there is outcome measures. There is no doubt outcome measures. We all keep on checking, but there are multiple ways of doing it. It may not be simple, the CLAPSy way. We need to check into multiple things. So this is something which we all need to do. My next topic is on VAP and VAE. We all know about VAP. We've been hearing it. But the second thing is also on ventilator-associated events. And hospital-acquired pneumonia is one of the most commonest nosocomial infection. We all know it affects approximately 1 in 100 patients overall and up to 1 in 10 patients on invasive mechanical ventilation. So true incidence of nosocomial pneumonia is very difficult because there are the diagnostic criteria which are not objective. The correlation is very subjective and it is also applied differently. So what for VAP we had initially was about simple things of looking at the X-ray and deciding. Now these things are changed and we know what is new is about actually measuring the VAEs, and VAEs also have a measurement of the VAP which is there, which is PVAP and IVAP and IVAC. So VAP and VAE, we all know, can cause a increase in the duration of the mechanical ventilation, prolong the intensive care unit stay, hospital length of stay, increase the mortality risk, and also use of antimicrobials and higher cost, which again is a big burden on the family. For VAE, one of the things which actually I have done a VAE pathway in my institute, and I'm very happy with it because there were a lot of bundles which we put up no, leaving across the VAP bundle. And it was a very big eye opener because VA is all about taking care of a patient on a ventilator on the whole. It's not only about prevention of the pneumonia, but it's also about prevention of fluid overload, ARDS, collapse, pneumothorax, multiple things which can further increase the incidences of VAP and further cause a mortality and morbidity. So again, in here, there is Shia has put up with the 2022 update. And here again, it has given the practices divided into essential, additional. Two more practices that they have put up is generally not recommended and no recommendation. So essential practices here are good evidence that the intervention decreases the average duration of mechanical ventilation, length of stay, mortality, and or cost, and it benefits likely outweigh the risk. Additional approaches are good evidence that it improves the outcomes in some populations, but it can confirm some risk in the others. It may lower the VAP rates, but there is insufficient data to determine the impact on the duration of mechanical ventilation, length of stay, or the mortality. Generally not recommended are inconsistently associated with lower VAP rates, no impact or negative impact on any of the outcome measures, like the mechanical ventilation duration, length of stay, or the mortality. And no recommendation is no impact on the VAP rates or other patient outcomes. And also there is no clear, there is a very unclear impact on what is the cost that is involved over there and how much is the cost difference. Then comes the essential practices, which are again divided into high, moderate, and low, which was the same which I told you. So high practices are about avoiding intubation and preventing intubation, re-intubation. This can be done easily actually because when the patient comes, we can very well give trials of non-invasive ventilation. We can give trials of CPAP ventilation. We can ensure that a proper extubation checklist is followed so that the patient does not land up with the re-intubation. So this is one of the most foremost thing that one needs to look into. Provide early enteral versus parenteral nutrition. Yes, it is very safe. We can do it. Change the ventilator circuit only if visibly soiled or malfunction, or if whatever is the manufacturer's instructions. Moderate is minimize the sedation. By minimizing sedation and by giving spontaneous awakening and spontaneous breathing trials, it gives a lot of benefit to all of us. Also, it helps when the patient wakes up and is not very delirious. This is one of the things which I have seen, because the patient is aware of the tube, is patient is able to understand what we are talking, and also the family is there who can make them understand. It really helps. And by giving this, we also get a confidence at the time of extubation, and we don't need to get more worried. So this is something which we need to really look into it. And one of the ways by doing it is by following the RAS scoring and the CAM ICU. So it helps this parameter to be taken into control. Maintain and improve physical conditioning. This is again one thing. So not all ventilated patients need not be, it's not that they cannot be mobilized. We mobilize the patients who are on ventilator, who are on CPAP ventilation, who have a good oxygenation level, who are hemodynamically stable, with a proper staff cover, and seeing to it that every aspect is taken care at the time of mobilization. In fact, mobilization not only gains their confidence, it also reduces the incidences of the collapse and consolidation, and it makes the patient, it gives the patient a lot of positive feeling that he is recovering. So this is something which we need to do. Provide oral care with toothbrushing, but without chlorhexidine. In nowadays, we have good toothbrushes which are available, and that really help us in giving a good mouth care. So this is something which we can do. Elevating the head of bed is a low evidence as of now. There are trials which are done, and they have not shown more of a benefit. Additional approaches, high is use selective oral or digestive decontamination in countries and ICUs with low prevalence. There are RCTs done, but there was a little difference. But this is again, some countries do it with antibiotics and all, but it all depends on which area you're and how you're. So that is what they are saying. Moderate is utilize endotracheal tubes with subglottic secretion drainage ports for patients expected to require more than 48 to 72 hours of mechanical ventilation. So this was one of the things of my ventilator pathway. And one way I had done it was that in the emergency room and in the ICUs, we kept all the endotracheal tubes with subglottic suctions and even the tracheostomy tubes. But OT, we did not push it more because we get the patients just for a short term. These patients come and they get extubated. They get extubated on table or within 24 hours in the ICU. But if this patient requires a reintubation, or if this patient requires the ventilator for long or a tracheostomy, whenever the change is done, we see to it that we do a subglottic tube insertion. So that is one of the ways which we have very nicely implemented, and we have been successful at that. Consider early tracheostomy. Obviously, most of the guidelines, including our age guidelines for the stroke patients, also say that early tracheostomy helps the patient's recovery also. Consider post-pyloric rather than gastric feeding for patients with gastric intolerance at high risk for aspirations. This all factors are very easily doable, and they also then prevent the aspiration and benefits every one of us. Generally not recommended to prevent VAP or VAE in adult patients. Like what Sir was saying in the introduction, there are multiple things: oral care with chlorhexidine, probiotics, polyurethane ET tubes, tapered endotracheal tubes, where reducing the size is one of the things that sometimes people do. Automated control of ET tube cuff pressures, frequent cuff pressure monitoring, silver-coated tubes, prone positioning. Prone positioning mainly for ARDs is what we use. Stress ulcer prophylaxis, and monitoring residual gastric volumes and early parenteral nutrition. So these are some things which are not recommended, and no recommendation for a closed endotracheal suctioning system as of now. But you have to see how is your environment, and this really needs a lot of strategy planning, because you need to see that your nurses are well trained in doing an open section. Both nurses, doctors, and every aspect of care is taken care, and also a monitoring is done and a proper training is done. Again, coming to performance measures, regular monitoring and internal reporting is very important. Both we have to, again, here do outcome and process measures. So this is something which I had done. It was not only looking at the outcome, but it was also on checking even to the extent of how many times the patient was mobilized and whether the patient was not mobilized. This is something which is very important. So the entire process, whether the patient was given the awakening trial, whether the patient was given the breathing trial, whether the RAS score was kept under control, all these measures have to be checked, whether subglottic suction tube was used. So all these compliance measures are the process measures which help us in understanding what are the issues, and if some things need to improve, we can do it, or if the staff is having any issues in implementing it, that can be done. And as I again told in the start, these measures need to be also informed to all the people, including the bedside nurse who knows what is the outcome of doing all this. Next is COTI. Yes, UTI is another one common infection. We all know the risk factors are duration of catheterization, length of stay, female gender, and drainage systems. So this UTI which is there, again, it is something which can increase the morbidity, the cost, and the stay. Okay. And calculations, we all know it is per 1,000 catheterized days, and it does not include the day the patient was catheterized. Okay. So this is something which we all need to know. COTI bundle is about using a standard indwelling urinary catheter kit, ensuring the proper insertion technique, and maintaining the catheter according to the evidence-based guidelines. Yes, urinary catheter kit. We can form a kit where there are multiple kits which are available, and it should have a closed system catheter insertion kit. Also, all the supplies in the kit have to be organized in such a way that each one is one by one to be removed, and consider removing the individual catheters which are there. So if you're having this kit, you can just remove the individual catheters to ensure there is a proper compliance to the kit usage. And a checklist to be used at the time of the insertion, because before the insertion, we need to ensure that we have selected the catheter properly. The nurse or the doctor who is doing has been trained properly. A proper hand hygiene, a proper perineal care is given to the patient, and strict aseptic precautions are followed. And also the inflation of the balloon, is done properly as per the catheter recommendations. So this is something which we all need to follow. Insertion technique, obviously perform the hand hygiene immediately before and after. Proper antiseptic solutions to be used, proper cleaning to be done, and also see to it that there is a sterile field which is put up. Use sterile gloves, drapes, sponges, antiseptic single-use packet of lubricant jelly for catheter tip. Secure the device after the insertion. Keep the collection bag below the bladder level. And if the catheter is accidentally contaminated, discard it and obtain a new kit. Do not use the same catheter. Maintenance bundle, use appropriate hand hygiene and gloves. Properly secure the catheters. Maintain a sterile closed drainage system. Maintain good hygiene at the catheter urethral surface. Maintain unobstructed urine flow. Maintain drainage bag below the level of bladder at all the times. And one of the most important thing is do not change indwelling catheters or drainage bags at any arbitrary fixed intervals. So if any hospital is following it, please stop doing it. It is not required. One of the things which we also follow is that when we are doing the catheter removal, we see to it that the patient has received the antibiotic before the catheter removal. So these are few things which we need to do. Every hospital may be having their care bundle, but it is how you go and check on the implementation. One of the preventive measures which we had followed in our hospital, and that's why having a zero COTI rate, is also that we do a supervised care training. So whatever is the care which is given by the nurses at the bedside for the catheter care, it is done in a supervised way, and it is monitored by the team leaders, as well as it is done even in the daytime, so that if there are any mistakes which are done at the time of the care, they are corrected to the nurse who is doing it. So these are few things which can be done, because there is nothing additional new that can be done, but these are few practices. It is all about changing the practices. So overall, in conclusion, measures to prevent device-related infections. First and foremost, definitely hand hygiene. I didn't go into the depth of hand hygiene because I know there is one more session on it. But hand hygiene is something, and as we all know, in hand hygiene, we all follow about using the hand rub and before touching the patient. But equally, few of the moments which are missed commonly are about touching the devices and also touching the surroundings when we come out. These are the places of non-compliance, but that is something which can be improved, and compliance with whatever bundles that we put up for the hospital. Training and monitoring is very important. Giving a feedback is very important, and family education, because we send these patients for home care. As I told you, we need to do a proper education. In fact, one of the things that we have started doing is we also want to train the families that if they see anybody is touching their patient without using the hand rub, they can very well stop. Another one way of actually improving everything is by empowering the nurses to see to it that if anybody entering the room without using the hand rub, even including the doctors or touching the devices, the nurse has the empowerment to stop it. And that can be done very easily. It's not about the ego, it's all about the patient safety. That's it.